So it's ADHD Awareness Month. Happy ADHD Awareness Month, everyone.
Hey.
Isn't that fascinating? So exciting. Lots of really cool things out there to do. One of them might be to sign up for the conference in Anaheim, California, which is next month, where Penn Holderness is going to be one of our headliners. And Kansas City's very own Sasha Hamdani is traveling to California to present as one of the headliners there. Next year, the conference is going to be right here in Kansas City, believe it or not, in November of 2025. So I'm thrilled about that. And you are all going to be hearing quite a bit from me as we kind of geared up for that. Let's see, why isn't this moving? There we go. We encourage everybody to join CHAD if you're not already a member of CHAD. You know, we do give away a lot of stuff for free, but you know, your membership helps make it possible for us to, you know, provide Zoom meetings and you know, provide information and services here locally. So please join CHAD if you can. It gives you access to lots of great discounts on future conferences, webinars, prescriptions sometimes, and other fun services. Later this month, our women's group is going to be meeting to talk about building self-esteem and self-trust. And if you have RSVP'd online, you will get a notice of where the meeting is going to be held prior to the meeting, hopefully. Next month for our parent group, we're going to be talking about ADHD in sports. So everything that parents need to know about their child with ADHD, participating and competing. Should be a really good presentation. It's going to be virtual. And all of our parent group presentations from now on are probably going to be virtual, at least for the next year. We've been having trouble identifying a consistent location to have the meetings. And I just feel like our online meetings are probably better attended overall. Plus, we seem to have a lot of technical difficulties sometimes when we're trying to do a hybrid meeting. So just to make it easier for everybody, we're just going to be online. You just RSVP for whatever meeting you want to come to on our website, ADHDKC.org. Excuse me. And we will send you the link. Next month, our teen meeting, which I wish I could go to both meetings because they also sound fantastic. Because I think things are itchy and loud and too bright. But they will also be on November 5th at 6:30 online. And again, just RSVP if you want to be there. We would love to provide topics that you want to hear about. So definitely scan the QR code and let us know if there's something specific you'd like to hear about or something different or some way that we can better serve you, because we would love to do that. Just as a quick reminder, we are a CHAD support group, which means that we do not endorse any specific product, service, publication, medication, provider, or treatment. And I'm super excited for our talk tonight because two of my favorite people in the whole world, Dr. Jordan and Kari Wold from the Jordan Psychological Assessment Center, are going to talk about diagnosing things, but most importantly to me anyway, ADHD. So what I'm going to do is stop sharing my slides and turn it over to you, Dr. Jordan or Kari, whoever.
Okay.
Let's see. Stop share.
Okay.
And then you can just share whenever you're ready and I'll take it from there.
All right. Hopefully that is
perfect.
Right screen. Yep.
You got it.
Awesome. Okay, so as Jeremy mentioned, Dr. Jordan and I are going to discuss diagnostics, specifically and mostly with ADHD, but there will be some discussion about why it's important to do a thorough and comprehensive diagnostic evaluation for ADHD because of other diagnoses that perhaps have some overlapping features or symptoms. And so we'll talk about all things diagnostics today. And so I'll let Dr. Jordan lead and then we will get started.
Yeah, and maybe we'll start with a little introduction. So I'm Dr. Kari Jordan and I am a licensed clinical psychologist. I have been specializing in diagnostic assessments for 30 years, a very long time. And ADHD has really been at the forefront of that area of specialty for a really, really long time. And so have been growing our practice and including more people. Kari's been on board with me for about a little over a year now. And is that right? And and working to do our diagnostic assessments. And so this is a topic that's near and dear to my heart, and something that I'm really I'm passionate about, people understanding why an assessment is important and those kinds of things. And Kari, tell us a little about yourself there too.
Yeah, so I'm Kari Wold. I'm a licensed master's level psychologist. And as Dr. Jordan mentioned, I have been with Jordan Psychological for just over a year, but I've been practicing and doing diagnostic evaluations for the past 8. It's an area that I really enjoy doing because helping people kind of have a better understanding about what they're experiencing and maybe what their loved ones are experiencing is something that I think I have found a lot of passion, and I think it's very useful. And I think really giving people knowledge based on really, good objective measures and engaging in good practice is something that I'm really passionate about. So I'm excited to discuss that more in depth. So
Yeah, good. I will take the slides here. So this is one of my favorite little analogies here is the elephant story. And everyone has heard this, but I think it's a good way to start thinking about assessment, because what I try to think about is really looking at the whole picture and trying to get a really good bird's eye view of everything that's going on. And so of course the story with the elephant is, if we have a blindfolded or blind people feeling different parts of the elephant, they're going to describe different things. If someone's feeling the trunk, they're going to feel one thing, the tail another, the ears, the tusk, and no one's got the overview when they're doing that. And so that's what really we try to do, is bring all of those pieces together and really look at a person holistically and thinking about lots of different areas of functioning, and try to bring that into a unified whole to really understand a diagnosis and what the person is struggling with and where their strengths are, so that we can have that nice holistic view and really present suggestions for where we can go forward from that big bird's eye view, rather than just little snippets and pieces here and there of all of that. So that is my pretty elephant picture there. And I'll also just mention this. So one reason we also think about really doing an assessment from a large perspective is that here I've listed a bunch of different things that could occur, that people could struggle with, and all of them have kind of an underlying thread, which you can probably guess is attention and struggles with focus. And so it can come from different places, and we really want to sort out what's the root of that, what's the underlying reason someone is struggling with attention and focus. There may be lots of reasons for that, and we want to make sure it's not that someone has poor hearing, or that someone is anxious, that there's what's kind of going on beyond underneath all of that, so we can really sort out. And maybe it's both. Sometimes it's more than one thing, and that's another thing we'll really think about as we're looking through things today. It may be both and, but we want to really have a good overall view of all these different things and be thinking about all these different things as we're doing an assessment. Kari, you want to take this one?
yeah. So why test for ADHD? So having confidence in the diagnosis. If as Dr. Jordan mentioned, if you're touching the elephant and you're only doing off of one section, you don't have a whole nice broad picture. But as we know, with recall and accurately describing and recalling information, going off of subjective, so what we just see and what we assume in our perception isn't always the most accurate, or is it reflective, nor does it give you that big broad picture. And so pulling in objective measures to really look at factual information is incredibly important. And we'll talk about the different measures that can be used, but having confidence in the diagnosis of ADHD when you actually provide the diagnosis is incredibly important for us as clinicians. We also want to rule out other conditions. And so on that previous slide, it talked about other conditions, but some conditions, actually many conditions, I would say, have overlapping symptoms. And so, for instance, attention, as Dr. Jordan very nicely mentioned, was incorporated in all of the diagnoses on the previous page, but some things, for instance, such as anger or difficulty regulating emotion, can also be seen in things like depression. And so, which we see also in ADHD diagnoses at times. And so we want to rule out or rule in other conditions that might be either comorbidly happening, so they are co-occurring with ADHD, or perhaps say it is not this, but is indeed this. And so we want to make sure that we're actually doing a thorough assessment to figure out what it is that's really happening for the person. It gives us a greater understanding of the child. So when we look at measures that we use, when we are even using subjective measures, so again, we're getting the person's perspective, we don't just go typically with one person's reports. We might look at a couple of caregivers, so parents, grandparents, aunts, uncles, as well as teachers, so those others. So people across all environments to look at, what is this child like? What is this young person like across settings, across people? You know, how do they respond in novel situations, right? New situations. How do they respond in situations or environments that they're in very frequently? And so we want to have a good understanding of who is this young person sitting in front of us. And then we also want to use the data that we see, that we gather throughout the assessment process to help us guide the interventions. So we want to be able to say, if it is ADHD, for instance, um, how do they do sustaining attention versus, you know, task switching, or, you know, being able to actually respond appropriately to a given target. And so we're looking at so many variables so that we know, hey, they do okay, or they do pretty well with this, but maybe it's this they struggle with. And so when we're providing guidance, we can say, here are some areas in this particular area that might be of great help if you focus on this and help strengthen that area for that young person.
And I apologize for my puppy.
Okay.
Oh, goodness. So why is testing for ADHD so hard? That's one thing that I've always struggled with is that it's such a, it seems like people will say, oh, I just get a screening for ADHD? But it's much more complicated than that. ADHD presents differently in different people. It looks different in children or women. So we want to really make sure that we're thinking about what a different presentation might look like in a different person. It is a diagnosis that's really based on behavior. So it's not like we can just do a quick blood test and rule it in or rule it out. And again, we've talked about comorbidities a lot, but learning disabilities or depression or anxiety are often things that could be comorbid or co-occurring with ADHD, and that can often make it hard. Also, recently was testing someone who had a bipolar diagnosis and an ADHD diagnosis, and I'm really thinking carefully if both of those are warranted or not. So we really want to make sure that we're thinking through those comorbidities. Could also mimic other conditions. So medical conditions or other psychological conditions can also have that attention factor as well. And people are inconsistent. People can do great in one situation and really struggle in another. And so that inconsistency, well, he's great when he's playing video games. He can focus forever. But then, you know, you go to school and really struggle. So that inconsistency in behavior can also make things a little more of a difficulty. And then our social influences. So someone may really push through and pay attention really well in school because they really want to be liked and to be seen as good. Or on the other hand, the social influences from social media making people self-diagnose and you know, are presenting with things they've heard online. So those all can make that diagnostic process a little more of a struggle and more difficult for us as well.
So criticism of ADHD testing. As you can see on here, there are a few that are just labeled, but problems with diagnostic criteria is being one of them. And so over time, as the DSM has changed, diagnostic criteria has changed, and we've moved even from ADD to ADHD. And so just a brief overview, everything is now under the umbrella of ADHD. And so it is ADHD combined presentation, inattentive, or hyperactive. And so rather than having ADHD and ADD, it is all under that umbrella now. So when we look at the diagnostic criteria, there are several things that come to mind immediately for me, but one of the things that Dr. Jordan mentioned was the difference in how it's presenting across genders, for instance. And so you might see criteria in the DSM, for instance, and it may not look exactly the same for one person of maybe one gender as it does the other. Dr. Jordan, is there anything specifically that you're thinking of that comes to your brain from recent evaluations that you're like, this is one of those things?
I wish I could be on the DSM committee and help them rewrite the criteria. I
Yes.
don't think that they're as robust as they could be. I don't think that they're as thorough as they could be. I think there's a lot more symptoms we could include or rephrase to be a little more clear. I think a lot of the again, the ways it presents in women or ways it presents in girls can be very different than boys. And we tend to think of the, you know, boys kind of bouncing off the wall kind of presentation as being our sort of typical thought that comes, we're thinking about that. And I don't think some of the things like the emotional regulation you mentioned earlier, those are not included in the diagnostic criteria. And I think that's so commonly, you know, problems with anxiety or, you know, a little boy that's managing his anger or different things like that can also be struggles. And so those are not included in the diagnostic criteria. And so that, you know, maybe something in the future when they revise it might be something that might be included or clarified.
Yeah, yeah, no, and those are all very good points. And I think, we continue to revise at the SM and as we learn more and more about diagnoses. And so that definitely, those are all very good points. The second bullet is over brief evaluation and screening. It's cheaper and faster. As I mentioned earlier, and it was a very brief mention, but having someone complete or having another person complete like a very quick subjective measure, just saying, rate on these 10 questions, and then we provide a diagnosis. That is not, we aren't able to give a number of things by just doing that brief of an assessment. Giving good guidance and resources and tools would become much harder because we don't really have a lot of data to support the person's diagnosis that we'd be giving. We're also only relying on subjective measures. We're not actually using objective measures at that point, which are looking at facts. And so when we are using objective measures, it's testing a person's more or less a skill in the moment. It's testing this thing in the moment, and we're getting to see it live happening. So how does this person respond to tasks? How do they do paying attention for longer periods of time? Can they sustain attention? Are they losing focus? Are they struggling holding still? So not only are we getting this information through this particular assessment that we might be doing, we're also taking observational data. So we're getting to see, what's it like for them when they have to sit for these longer periods. And so if you think about a child who, for instance, is in school, right, that might be something that they might see in school. And so we're getting to see that in the moment. And we would entirely miss that if we just did a 10-minute or even if that, a very brief, screening tool and just to get in and get out. We could also, unfortunately, misdiagnose or miss a diagnosis if we just used a very brief measure because, as we've talked about several times now, comorbidity and other diagnoses looking kind of like it or, mimicking certain things, it could happen. And so we want to make sure that if we're going to give that diagnosis, that it actually is warranted and we have the data to show it. So that goes to the next one of I can diagnose ADHD just by watching my kid for a couple of minutes. Our evaluations are quite a bit longer than that. We do it over a couple of assessment days. And again, that lets us see what a child's like or person is like, because we also assess adults after and over a period of time. And so that lets us look at what are they like on any given day, on different days. We get to learn about what their sleep patterns are like. There's so many other variables, which is so reflective of their day-to-day life. And so that's a few minutes for us would not be substantial or sufficient enough to give a good diagnosis of ADHD or really anything else. Then we look at these last two. So ecological validity of test results and stigma of labeling. I am sure, I'll start with the last one. I am sure many of you, as you're watching this now live or recorded, have experienced or have heard of experiences of people who have experienced stigma of some sort because of a label they were given, whether it be ADHD or something else, or be having experienced somebody speaking negatively of people who are diagnosed with ADHD or something else. Maybe they're unaware that that person they're speaking in front of has a diagnosis and speaking very critically just because they have the label. And so we want to make sure that if we're providing this tool, right, this label, that we're doing so and it's actually warranted and it's going to provide them tools and resources to open up so many roads in their world. And that's really what we want to do. Okay, so purpose of the assessment. So first one's relatively easy.
Sorry,
We wanted to,
I didn't realize I was muted there.
oh, it's okay. You go ahead.
Okay, so purposes of the I'm just talking and not realizing no one can hear me. So purposes of the assessment, there's a lot of different reasons we are trying to determine if someone has a presence or absence of ADHD. obviously, some of those things could be not necessarily going to go in the order that they're listed here, but what I would say with children, one of the biggest reasons is to get some services at school, to figure out what we can do to make school, because that's where kids with ADHD so often struggle. How do we make school a place that is positive, where they're getting along with peers, where they're learning, where they're being successful, where they're not in trouble all the time? Um, I see little kids all the way down to preschool, and I have a lot of kids that are getting kicked out of preschool. And so we'll talk about preschoolers in a minute, but that is often, one of those first signs that, a kid who's just not able to kind of manage their behavior in that structured setting and kind of follow along the expectations there. Um, uh, then from that, may want to develop interventions, services, accommodations, ways we can make that school environment work for kids. We know a lot of things of ways that we can structure the environment that are often really simple stuff, that are simple, straightforward accommodations, like sitting the child in the front of the room, or finding an appropriate uh, type of seating, or fidget objects or different things like that. There can be some simple things that we can do that can really make a difference. And having the school provide those, be on board with those, can be really, really, really helpful. Um, Kind of going out of order here. Again, we've got the comorbid conditions we've mentioned. A second opinion. I get a lot of people coming in saying, hey, we had this diagnosis. I want to make sure that's right. So there may be a reason for either over time or more immediate to come to say, yeah, this is right, or this is, no, we might disagree with that, and figure out. Um, uh, Assessment is an art, and figuring out some of that. Did when we're doing a second opinion, was it done well? Was it done thoroughly enough? Are there new information and data that we want to consider to make sure that we're agreeing or disagreeing with that past decision? I also really think the last bullet point there is important, to identify the child's strengths. We don't talk much about the strengths when we're thinking about a presentation like this, but how does this child learn best? What are the strengths or I tend to say child because it's probably about 75% of the people we see are children, but child or adult, what are their strengths and weaknesses? How can we use strengths to accommodate for those weaknesses and really play to the strengths, so that the person's being successful at school, at work, in relationships, and in the assessment, we're really kind of able to identify, this is a place where they've got a great strength and we really want to use that. Here's a place that's a little bit weaker. We might need to accommodate that. And so we're able to kind of balance those strengths and weaknesses to help them be as successful as possible.
All right, so testing and medication. So with medication management, some physicians and insurance companies do require a diagnosis from a reputable or a licensed provider in order to prescribe, or before they will prescribe and or cover a medication. And so actually having a true diagnosis on paper, they can provide the clinician or the physician, nurse practitioner, whoever the person is. We do see that pretty frequently. And then again, testing and proper diagnosing can inform what medications actually will serve this person best. We don't want to see somebody being medicated for something that isn't what's going on, because then it wouldn't actually treat the symptoms and it could cause things to be worse, depending on what it is. And so that's incredibly important when it comes to medication management and direction.
And I'm really happy that this is a trend. I have a lot of pediatricians and psychiatrists that we work with that really want to have that firm diagnosis before they'll move forward with ADHD medication. It's sort of, the pendulum has swung. It used to be, when I was doing this a gazillion years ago, pediatricians would kind of throw medication at kids. Now let's see if this works or not. And I don't think that that's a very thoughtful and efficient way to do things. I think gathering data and getting a good diagnosis first, and then figuring out what medication may be best. And like the child I was mentioning earlier today, who has both ADHD and bipolar disorder, that's important to know that, and to understand why an ADHD medication alone is not enough for this particular kid. And so we can understand really having that full picture of what medication is going to be helpful. When is it time for testing? So that's a great question. When there's any kind of diagnostic uncertainty, so we're not sure what is this? So we don't know how to treat it. We don't know what to do. So that's a great time for testing. When behaviors are causing significant disruption or distress, like the kids getting kicked out of preschool, or a child really struggling in school, or an adult not figuring out why they're having so much struggle at work and why that's, they're not getting the promotion or they're not getting the job or things like that. I love this one, just so we know what we're dealing with. It's a lot of relief for parents and adults also to know, okay, that's why I'm struggling. I'm not stupid. I'm not all the other things that people may self-label when they're struggling. And so to understand that diagnosis can lead to a huge relief to understand and just that self-understanding as well. Again, child that's frustrated or failing, and again, for access to services. So a lot of different places, maybe medication, maybe IEPs, that a formal diagnosis and assessment process can really open those doors to all those different services that someone may need.
So what is psychological testing? So that is what we do. It's evidence-based assessment. We use assessment and we use measures that are evidence-based. That means they have been researched. They have gone through numerous studies. I mean, there are so many things that happen behind creating a test that has reliability and validity. And so we look for those things. We want to use measures that show, is this test measuring what we're hoping it measures for? And so it has to go through this whole long process or processes in order to become evidence-based. So we utilize tools, and we hope many clinicians do the same, by using evidence-based measures. We want to make sure that what we're assessing for is actually we're using tools that actually measure those things and those symptoms. And so research and theory is used to inform the assessment process. So I mentioned reliability and validity are just two of the things, the context of the instruments. And then we look at, can this be used in clinically? Can this be used, in the office? Where are these measures being assessed when they're going through the research process? Where are they being tested? In what populations are they being used when they are going through the process of being or becoming, I should say, evidence-based and supported measures? But that is psychological testing in a very brief overview.
And I'll add, that data is so important. It's not just an opinion. It's not just, we're not coming to this just based on our opinion. We're really gathering data that informs those decisions and those diagnoses. So a lot of people will call or inquire about a screening. And I'll just mention really quickly about a difference between screening and an assessment. A screening would be something that's just brief, very limited in scope, may suggest further testing. So we don't do screenings in our office very often because we'd rather just go full on into it. But if we did do a screening, it might just be a brief a discussion or a brief questionnaire. Pediatricians will often use something like the Vanderbilt assessment that's just meant to be a screening. Yeah, this is something that, we should look further into this. Or like if the little child with autism, we might use an MCHAT in the pediatrician's office. Yeah, this looks like we need to go further and get more data about that. An assessment, in our view, is comprehensive. So we're really looking at gathering good data across multiple domains. So we'll look at, and we'll go through a lot of these different things in a minute, but we're looking at different areas of functioning: executive functioning, attention, intelligence, academics, could be different things depending on the person and how their age. We're also getting multiple sources of information. So it's not just someone coming in saying, hey, I can't pay attention or I'm fidgeting all the time. We're really getting that data from, like Kari mentioned, watching them. What do they do in person? What does their parents say? What do their teachers say? If they're an adult, their partner, their mother, we try to get mother and dad and father from adults. So we're trying to get that information from multiple sources and trying to look at that data being all in agreement and coming together in a convergent way. So using multiple measures, again, things that are self-reports, things that are observational, things that are objective data of someone doing something and how they perform on that. And then we're using our diagnoses based on the diagnostic criteria. So again, it's not our opinion. We're looking at the diagnostic criteria in the diagnostic manual, which is called the DSM-5, to see, does this set of symptoms and behaviors we've got in front of us meet that accepted diagnostic standard?
how young is too young? Okay, so all toddlers have ADHD, right? We know that all toddlers are active and they're busy and you know they're exploring the world and they're learning through experience. So we're not denying that young people are busy. And so, but we also want to make sure that you know we are actually when we are providing diagnoses, we're not just going with, oh, this child's just a busy child, right? We're looking at, as Dr. Jordan mentioned, what set of things, maybe busy is one of them. And when we look at busy, what does busy actually mean? We'll talk a little bit about that. But what set of things are they presenting with, and does it fall into that criteria in the DSM? So we're not just going with the, oh, they're just an overactive child, or they're always on the move. What does that mean? What does that look like? And then what other things are you experiencing with that child? As it says on the slide, young people or young children have poor executive functioning skills, attention and impulse control. These things are gained and acquired over time. They come with age, they come at different stages in development. And so we want to make sure that we have a good a good understanding of what markers are met, maybe what areas are perhaps slightly behind based on research compared to similar aged peers. We're going to be looking at a number of things when it comes to a child who comes in that maybe has poor impulse control. Is it age typical? Is it slightly age, you know, is it not age typical? So we're looking at all of these things very, very closely and not just on opinion, but on research and on data that shows kind of what we should be anticipating. When we look at developmental evaluations, as I mentioned, we want to look at, is that development on track? When we think of similar peers of the same age, what is their development like? Are they in that same range? Is this child slightly behind? Are there other explanations? Most people or many clinicians don't diagnose before the age of 5 in regards to ADHD. There are some who will diagnose at 4 and younger. I think on those cases, and Dr. Jordan, feel free to share your experiences with that. The cases I have seen are cases that are typically pretty extreme in regard to behaviors. The behaviors are very, very, when we think of development, as I mentioned just a bit ago, and as Dr. Jordan mentioned previously, the behaviors and some of the areas of development are so far delayed. And they're so impacted by the behaviors of maybe hyperactivity or unsafe behaviors and impulsivity that perhaps it is warranted at that time.
Yeah, and I think that age has kind of lowered a little bit. I think that people used to be really sort of fearful of diagnosing too early. But you know, was maybe 7 and then 6 and 5, and I personally am seeing more and more at 4. I'm seeing a lot of kids that are like being kicked out of preschool, like I mentioned, and having that real struggle in that situation. And so again, we're taking that context of, is it a language delay? Maybe that's why they're having the behavioral issues. Is there autism? Is there something else going on? Or does this look more like an emerging ADHD pattern? And a lot of those behaviors in little kids are things like sensory behaviors, tantrums, meltdowns. There's lots of different kinds of emotional regulation behaviors. It's really kind of that self-regulation that we're looking at in those little kids to see, where does that fall? Is it more of a global developmental delay, or is it autism, or is it looking more like an emerging ADHD kind of pattern? So it can be really tricky in little guys to try to sort that out. And so sometimes I'll kind of hedge my bets and say, it looks like an emerging ADHD. I'm not 100% certain yet. Let's kind of monitor this and move forward, especially when they're really little. Let's see. So testing at different ages. Uh, like we said, in little kids, preschool kids, we're really looking at development. Where are they developmentally? What's happening? Are they making those skills as expected, gaining skills and growing? Especially language tends to be a big one. So lots of kids have language delays. As we're seeing, is that language or cognitive delay or some other type of delay really impacting that behavior, and then they look like ADHD, but instead it's some other kind of lagging or delay. And little kids, we could include cognitive. We can do an IQ test with little kids. There are developmental tests that look at cognitive development, even down into little people, or other developmental tests of language, motor skills, cognitive skills. We'll look at social development. That's an important one. Really, that rule out of ADHD versus autism, or both. Definitely can be both. So we want to really look at that and see how that social development is. We'll use lots of behavior rating scales, which are those, if any of you guys have done these questionnaires that have lots of multiple choice questions about rating different behaviors on a scale from never to always, is usually the kind of scale that it is. And so we'll ask parents to do those, teachers to do those, daycare providers. So we have a really great sense of what this kid is like out in the real world. It's not just based on what we're seeing or based on parent reports, but we're seeing that that overall piece as well. Adaptive behavior is more daily living skills. How are they doing with feeding, toileting, language development, social development? So it's looking at some of that real world daily behavior. And that's an important piece, especially in little kids who might have some kind of developmental delay. We want to see where they are compared to peers with that.
Okay, so when we talk about testing different ages, including elementary and high school students, we again use typically comprehensive evaluation. So we're going to do very similar things that we would do with younger people, but we're going to use different measures. And so we're going to use measures that are appropriate for that age group. And so when we assess the wee littles or the young children, we might use one measure for cognitive. We're going to use a measure that is age appropriate for the elementary and middle school and early high school, and then even switch gears once we get to high school. And this is just, for instance, for IQ. We're going to assess how that impacts their ability to engage in school and learning, maybe other activities. So if they're in high school and they're involved in clubs, they're trying to be involved in sports and they're just really struggling with, impulsivity maybe, and they can't play on the field because they're just too reactive. So we're going to look at how is this impacting that environment. We're going to figure out, how is it impacting learning? Is it causing learning problems or contributing to maybe other learning problems that they're already experiencing? And then again, we want to examine how do the behaviors manifest in different settings, in different environments, and also with different stimuli present. Stimuli on the field, for instance, if you're playing a sport, is going to look very different than stimuli in the classroom, or when you're in a smaller group setting doing a class group project. And so we want to see how is this young person being impacted across these environments, and then we do want to hopefully and ideally help them gain access to school intervention and school-based services so they can receive the help they need in order to be successful or more successful in school and feel confident in what they're doing.
And I would just tag on one thing there. A big focus in elementary and high school age kids is academics, how their school is where they are so much of the time. So we really have a big focus on that. Mm-hmm. Adults, our testing for adults can vary depending on the purpose of the evaluation. So if an adult is still in college or still in school, we may really want to include academic testing to make sure they're getting any kind of accommodations they may need. But if an adult is done with school and working in their job, we may omit that academic piece, unless they're saying, hey, I wonder, maybe I also have dyslexia. That's something I've always wondered. So that may be included if that's one of our questions. And we'll do more things sometimes with adults that look at planning and organizing and some of those executive function. We've got some great tests that look at some of those skills in adults. And in our purposes, sometimes we may do a slightly briefer evaluation for an adult, just if we're leaving out that academic piece that can be time consuming. And so we may do a slightly briefer evaluation if they're really saying, hey, I just am trying to satisfy the psychiatrist's request for me to get a formal diagnosis. We don't need to include the academic testing. So we may be able to do a slightly briefer evaluation in that kind of situation for an adult with that.
Okay. So what's a good assessment? It is broad enough to examine comorbidities and rule out, right? So we want it to be able to look at the whole person, as we talked about at the very beginning with the elephant. We want to look at all of the things that they're experiencing. We want to look at the different parts of the world as much as we can in that time frame that we have with them. We want to be able to do that because, especially as individuals age, there may be other things that are present, and sometimes even with the adults especially, there's so much history that we have to explore with them. And so we really want to make sure that we're looking at the picture at a large enough scope and broad enough scale that we're really looking at, if there is comorbidity, what is it? And we can also do those rule outs. Those are incredibly important. We want to also look at the problematic areas and really look at what do those problems truly look like once we actually dig into them a little bit. It's easy to say, well, I don't focus, but not focusing may look very different for one person than it does for someone else. And so we want to really make sure that we understand when someone says, I have a hard time paying attention, what does that mean for you? Right? What does that mean in your world? How is that impacting you? And then we also want to make sure that when we're doing a good assessment, we're giving them resources and recommendations that are going to help them gain access to intervention and treatment that is going to help them live a higher quality of life that is meaningful for them and whatever that looks like. And so that's why getting a very good, well-rounded assessment is so critical because we want to make sure that as we're providing guidance, we're providing them guidance in the right direction.
This is our little graphic that kind of shows what our process looks like. We start with an intake interview where we're gathering that data, we're getting history, really talking about what concerns bring someone in, always asking about early development, seeing ADHD as a developmental diagnosis. And so we really want to see, does this date all the way back to childhood? What were you like as a kid? And if it's an adult, or, if we're talking about a child, getting that birth history, developmental history, and really seeing what that looks like. So we call that an intake. And then we do the formal assessment, the formal testing, and then we do a feedback meeting to go over results and share what diagnosis we found, or maybe sometimes we don't find any diagnosis, but we're still able to communicate strengths and weaknesses and suggestions based on that. And then we also write up a report that has all the test data in it. There's lots of recommendations, where to go, books, resources. We always include ADHDKC as one of our recommendations in CHAD. So those kinds of things we think will be helpful for people in that process. Jeremy, how are we doing on time?
I was just say it's about 7. We got about 15 minutes left.
Okay. Perfect.
Can you hear me? Okay.
Yeah.
Perfect. Thank you.
Okay. So when we do the intake, and Dr. Jordan showed you that very nice but very direct figure. During intake, we're looking at all of these areas. So we are looking at everything from their history, their background history. So everything from early on birthing, development, through toddler years. We're looking at peer interactions from the time they really started peer interactions to current. We want to look at, what are those peer interactions like? For instance, what does a peer interaction for them look like if they struggle? What do the struggles look like? And what are the strengths when they have strengths in those areas? We want to look at their academic performance across the different ages. If they started to struggle, at what age were those struggles starting to be seen? Maybe at what age was the school starting to really start make those reports to you as a parent or caregiver that, hey, kiddo is really having a hard time. When did that occur? And so we're going to look at all of these areas to really gain a good picture of this person outside of the testing that give us some good observational and historic data as we're building up to the assessment day.
And behavioral observations. We've touched on this a little bit as well. So I think it's so important to really see sort of why in the process underneath that. So 2 people could get the same score, but it could be like I wrote here, someone may be impulsive and not check their answers, but someone else is taking their time and second guessing themselves. Someone may just not know the information. Someone may be just, whatever, I don't care. And, not making a good effort. So there's lots of reasons that those same scores could occur, and that really, we're watching and taking notes and really paying attention to how someone is attacking those tasks that we're giving them to see what they're doing and why that is. So the kind of looking at that reaction to the testing tasks and the testing situation, their behavior during testing. We do include what's called effort testing. So that is really giving us, we want people to be making their best effort, because if people are not making their best effort while we're doing testing, it doesn't give us the best data. So we include effort testing as we're going along, and that gives us that good information if we need to say, hey, I'm wondering if maybe you need a break, or we need to talk about why the testing is important. Really have especially with kids, get them to have that buy-in and understand why what we're doing is important, and that they need to do their best on that. So those are all important pieces of that.
So as Dr. Jordan mentioned earlier, we assess in our practice, we're comprehensive assessment. So we assess a number of areas. So everything from cognitive, intellectual, so those IQ tests, to academic testing. We look at assessments that really focus on attention and concentration, executive functioning, language. We look at the whole person, because again, as we discussed and we've mentioned, there are so many things that could look like other things. And so we want to make sure that, is this person avoiding, for instance, classwork? Is it because of this, or is it because of this, right? So if the question is, well, we don't know if they're really understanding the material. Well, if we do an assessment that maybe looks at some of those things and we're saying, well, they're showing average or maybe even high average scores, that doesn't appear to be it, then we can kind of rule things out. And that's just an example. But we want to look at that whole person. We also would expect that, there are times with certain diagnoses, that if an individual has scores that are maybe slightly lower in this area, we might anticipate that they might be slightly lower in this area too. And so we look for discrepancies even, like, well, why is this so, average or even high, and why is this so low, and what does that tell us? And so we're really gathering all this data and using all these tools to help us really paint this picture to figure out, what does this mean about this person sitting in front of us?
Yeah, and really that pattern of data is so important. So if we're looking, like she mentioned, there's certain things that can predict if you get this score, you probably would get, a struggle here as well. And we're looking for all that data to make sense in patterns. So that's really a lot of pattern analysis. So this again is just another way of showing all those different things that we're looking at in those different processes. We're thinking about working memory, processing speed, goal-directed behavior, executive decision-making, attention, problem solving. So lots of different areas, how those all fall together in the different tests that we're doing to look at those different processes. This is, I took this picture when I had given this talk like this many years ago. This is my old testing closet, and I just wanted to show, and this has grown. This is probably double the size now. We have an even bigger testing closet, but this is just to show lots of the different tests that we have in here to look at all those different areas of functioning. This picture probably is, I don't know, maybe 8 to 10 years old. So I've got a lot more tests and updated tests than this now, and I've outgrown this little cupboard. But really, we're looking at all these different things with lots of different tools to really be able to kind of drill down into all those different areas of strengths and weaknesses and get some really good data from that.
So here's some examples of some of the tests that we use for intellectual and cognitive. So we talked earlier about using that evidence-based assessment tools in one of the previous slides. So we use a lot of the Wechsler family tools, so things like the WISC and the WACE and the WIPSI. We also use the WJ Woodcock-Johnson tests. We have the Stanford-Binet, the Kaufman, the KBC2 is also another good measure that is used to assess for IQ. So these are just some of the tools that an individual and a clinician may use when they're assessing for IQ, or full-scale IQ is oftentimes what you might hear.
Yeah, and these are always being revised. That's why they've got the numbers after them. Those are the version numbers, and the Wechsler Adult Intelligence Scale 5 just came out very recently. I just gave my very first one today. So it's like candy for a psychologist at Christmas for a psychologist to be able to use a brand new test. So that was very exciting. That was the fun part of my day. Well, besides being with you all. Academic achievement, again, we have lots of different tools we can look at. Broad achievement, so one called the Wyatt 4 is a great broad test that looks at reading, writing, and math. And then depending on the referral question and how they do on the broad test, we may drill down into some of the specific areas like reading or math or writing. And we've got lots of tools that will help us really, is someone having trouble with reading comprehension, or is it reading decoding, or is it reading fluency? What's going on within that process? And that then again informs diagnosis and intervention based on all those kinds of things.
Okay, so we'll go through these other tests pretty quickly just because I want to make sure that we have time for questions at the end. So
Yep.
we do memory tests as well, and we look at a number of areas, including work memory, long and short-term memory. There are a lot of tests and really good quality tests out there to look at what's an ability or an individual's ability to sustain or pull things from working memory. So
And then attention. So we try to measure attention in a couple ways. You may have heard of what are called continuous performance tests. These are sort of the famous computer-based tests where someone is pushing a button of some sort in response to things flashing up on the screen. And that really helps us see how someone sustains attention or continues attention over time. And those are some of our really great measures. We would never use that in isolation, but it does give us some of that. Okay, here we were able to capture someone's ability to pay attention to something that's not very exciting over a period of time here in the office.
and with these executive functioning tools, very similar. So many of these may be a computer, some of these are computer-based tests where they're doing the same thing. They have to, they're given a set of instructions. They may have to respond a certain way, or they're expected to respond a certain way. And we want to look at, what are they doing as far as doing things in the correct order, or maybe sequential reasoning. And so we're going to be looking at a number of areas when it comes to executive functioning.
And then rating scales. So these are the things that we can get parents to do, teachers to do, and self-reports as well. So we can, depending on the age of the person, get them to also sort of self-reflect and tell us about how they're experiencing. It's interesting to me a lot of times with adults that the adult is telling me, oh, I'm feeling all these really big symptoms. Feel so restless and I'm struggling. And their, spouse or their mother's like, oh, you're fine. And so it's like really, it leads to this great conversation about how much they're struggling to manage and look okay in front of other people. And it really can open up some great questions to look at those differences and how someone's perceived in different ways by different people across different settings. And we can look at, again, those broad-based things that look at lots of areas of behavior. We can drill down into certain things like executive functioning skills or depression or different things like that, depending on what we're looking at and what questions we're answering.
So with additional steps, we're going to perhaps ask the school either for their own observations. At times we may go in and ask to do observations depending on what's happening with the child or the individual. We will also gather information at times from other individuals, professionals in their life, like other therapists or psychiatrists, teachers, individuals that interact with that child pretty frequently, or perhaps more frequently than we do, because oftentimes we are new to them. And then we do a lot of reviews of school records, IEPs, documents, sometimes even like child's writing samples if writing is a question, just because we want to know, a little bit more about them and what those experiences are like, both immediate and also long-term.
And then the feedback. So the feedback is that point where we kind of take all the data and we're looking for those patterns of strengths and weaknesses. Does this meet criteria for any kind of diagnosis? Being able to share how that data fits into that diagnostic framework if there's a diagnosis. If not, explaining why there is not a diagnosis. Again, looking at those strengths and weaknesses. It's not uncommon that we find something unexpected. So, hey, look, we also have a reading disability, and maybe that wasn't expected. So how do those problems relate to each other? How does struggles with attention impact the ability to read? And then the struggle with reading impact the ability to pay attention. And so how those things can sort of snowball and exacerbate each other. So we'll always include that discussion of the diagnosis, prognosis, and where do we go from here? So, okay, we found XYZ. What are our next steps? What do we want to do? What kind of tutoring, medication, executive functioning coaching, what kind of strategies and tools could be helpful? And we've developed really big resource lists as well that we like to share with people also to include websites and books and all kinds of great resources from there.
In the report, we include all the history, all the information we gathered during the intake. We also include all the behavioral observations that we observed in the assessment. We talk about all the assessments we administered, what each assessment was looking for and what it found. We do a very thorough review of the test and the results and what that means diagnostically. And then we provide a ton of recommendations at the end to help guide intervention.
Yeah, we are known for producing very long reports. And so, but we want to be thorough and make sure that people have a really good record, because a lot of times this is one of the first times that someone has had all this information pulled together, and it's really helpful for schools and treating providers and to have all that data together in one spot, and really helps just jumpstart any kind of treatment or intervention by having all that data together. Um, you want to take that one?
Yeah. So, how do you diagnose ADHD based on test results? And so, as we talked about earlier, we're looking at patterns, common in ADHD in both children and adults, depending on who we're assessing. So we're looking at the behavioral patterns we see. We're looking at the results of the tests that were administered. We're looking at how do each one of the tests, how do they speak to each other as we're looking through all of the data? Oftentimes our desks are very full of paperwork as we're going through the work, because we're looking at what does test A say next to test B, and what does that mean when we look at them together? And then we have the DSM out, because we're also looking at, well, diagnostically, are these things mapping on? So we want to find those patterns that we would expect to see, or at least leading in the direction that we would expect to see of ADHD if we're going to be going in that direction of that diagnosis. We want to integrate data from all the sources that we talked about: teachers, caregivers, tests that we did, objective and subjective. So we want to look at all of the things as a whole. We want to make sure that the tests and the results from those tests align with the diagnostic criteria, as I mentioned with the DSM-5 and as mentioned earlier. And then we also want to make sure that we have enough information for accuracy and certainty when we provide a diagnosis, especially when we think of things like intervention, both medicinal but also behavioral, because we do know that certain diagnoses respond maybe better to certain interventions, or they may need certain intervention.
Yeah. And so this just kind of shows that, again, we're looking at that, thinking all this, I've, developed sort of this little tree in my head about ways I'm thinking about the patterns of data and things. So this kind of way of trying to show how that all goes together. We're looking at the symptoms we're seeing, how often they're happening. Is it expected for a developmental age? Something like, I like to joke that I have many little ADHD boys who are, 4, 5, 6 years old, that come in my office and they'll run behind me and grab, I have a little Yoda figure on my desk. They'll come behind me and grab Yoda off my desk. I have never had an adult do that. So things that are expected for little boys are very different from what we expect from grown-ups. So where does that fall in developmental expectations? And then the duration. So an ADHD diagnosis is not something that happens brand new to someone and an adult, and we want to see, does that extend back to childhood? It may look different. It may have been some people may not really show the symptoms or seek a diagnosis until something happens where they've met sort of that threshold where this now is hard enough for me that this, I can't kind of manage and control this. And so now maybe I've hit college and it's really hard to manage all those different classes and to be on my own. And mom and dad used to help me, and now I'm not able to. That we can look back in child and say, yeah, look at how they were, kind of being your executive function for you, and now you're on your own, and that's not there anymore. So we're again looking for that lifelong history, and then those are all the ways we might get to that data. And I think we've kind of touched on these, but these are
Yep,
some
we
of the
have.
different things that might co-occur, and we often will diagnose ADHD and something, one or more of these, especially the learning disability. I would say especially, well, actually the first set, learning disabilities, autism, and anxiety, seeing a lot of comorbid diagnoses. Showing my age, when I first started doing testing, the question really was, is it anxiety or ADHD? We're always trying to say either or, and people were really focused on, well, if someone is anxious, they can't have ADHD, or someone has ADHD, they can't be anxious, and really trying to be either or, and really that dichotomy. And I feel like we really have come to a place where we're doing both. And I see a lot of diagnosis of ADHD and anxiety, and so a lot more understanding how those things can be comorbid has evolved over time as well.
So as we mentioned earlier, we use the testing to provide recommendations and to help guide treatment. But then the testing that we do does inform people's treatment and informs which direction they go. And so we use the data to help give direction and help guide. And then that then informs which intervention or treatment they go towards. We want to look at, again, what areas are they impaired, or perhaps what areas are they having difficulty. That way they know which things to focus on and target when they go into intervention. We want to look at all these other areas as well. So are there comorbidities? What are they? And what recommendations do we give for one, the other, or both in order to target? Because we're looking at managing or treating or providing supports for maybe the things they're struggling with, whether it's behaviors or maybe it's a difficulty in learning. And so we can't maybe just focus on one, we need to focus on the whole. And then again, what are the strengths? What are the assets that we build on to support that person, empower the person while teaching in them in areas that maybe are very difficult for them?
Absolutely. So again, just a little talking about how that testing informs treatment. And I think this is a really good way to go with having the really good understanding, and then we can really target treatments. We don't want kids, for example, to be in some sort of intervention every day. We want them to be a kid. So if we can say, this is where the greatest need is, or this is where we think the best bang for our time can be, and really figure out ways that we can have the best interventions to really make that best real world improvement and outcomes. So just try to think that data driven process can really help inform that treatment process as well. And I'll just kind of continue there, since sort of looking at school, really the biggest things for kids often is an IEP or a 504 plan, depending on their level of need and their other diagnoses. Oftentimes kids with ADHD will not necessarily qualify for an IEP and might have that 504 plan, which is more behavior and support driven. And do they need accommodations in the classroom or testing accommodations? And again, we've got the data to show why they need that and how that diagnosis is impacting that functioning. Any kind of behavior plans or other interventions at school. Some kids may need a special school placement. So maybe this school is not the right one, and we need to think about a private school or a different school setting, depending on that need. And then we try to give resources for teachers too. Teachers are doing their best with not much resource and not much training, although it's definitely getting better over time as well. But we always try to provide some resources for teachers in our reports as well, so that they've got some, we're not just telling them what to do, but giving them, support and resources as well.
And last slide, so reevaluations. We most commonly see them when people are transitioning to a new school or perhaps level of schooling. So from middle school to high school or elementary to middle, or even going into college. If it's needed for special situations, they need it for ACT, SAT, the GRE. I mean, a number of things that would be helpful for them to be able to get accommodations while they're doing these very important tests to take them on to the next area of their life. If there's a change drastic, maybe in behavior and functioning or functioning at school or other settings, because it doesn't just have to be at school, but oftentimes, that may be one of the areas that we're hearing a second opinion from. And then also to update and progress monitor. Reevaluations also occur sometimes, and it's not on here, when maybe the person is aged and they're an adult and they were last assessed at the age of 10 and they're now 35 or 40, and they don't know what all the things and numbers are anymore because it's been so long, and we've learned so much through research now that having updated information so they can better inform the directions they go, whether it be because they're trying to switch jobs or maybe they're trying to get into the workplace because they've been unemployed for a while. And that's another area we often see that for.
Absolutely. Yeah. So there's our contact info. So Jeremy, do we have questions or things that we can answer?
I am not seeing any questions in the chat. If anybody has any questions, please go ahead and post them now, or if you think of them after the talk, that is fine too. You can either email me or email Dr. Jordan or Kari directly.
Yeah, there's our emails. We're happy to take those. Yeah.
Yeah. And if anyone's interested in an assessment, they should call your office, right?
Absolutely. Yep.
Awesome. Cool. Thank you all so much for being here. Thank you for your time today, Dr. Jordan and Kari. This was fantastic. I'm a total data nerd and I love all of this. So yay, let's talk about assessment. I want to hear some more.
Yeah, we love data.
Thank you all for coming. We appreciate it.
We do appreciate it. Thank you so much for having us.
Absolutely. Have a fantastic evening, everyone. And again, thank you for being here. Happy ADHD Awareness Month.
Yeah. Thank you.
Bye-bye.
Bye.
Thank you. We got more people.
Thanks so much.
Yep. Have a good night. Take
All right,
care.
bye-bye.